Hi, my name is Scott Suko, and I'm the Executive Director of the Northeast Ohio Liver Alliance. And welcome, and thank you for being part of our liver Q&A. Today, we've got a great topic and a fantastic speaker. Joining us is Dr. S. Martin Cohen, and he'll be talking about viral hepatitis, how to treat in 2021 and beyond. Dr. Cohen is a Medical Director of Hepatology at UH Cleveland Medical Center, and also a founding board member of the Northeast Ohio Liver Alliance. So thank you so much for being here and sharing your wisdom, Doctor. And with that, I pass it on over to you.
Well, thank you very much, Scott. We're going to have Scott advance the slides. We had a little bit of a technical difficulty, but we'll make this work. And so I was tasked with talking about viral hepatitis current treatment, and we'll look forward as well. So next slide. Can we get the next slide, Scott? There we go. Okay, so I'm going to talk about two things: hepatitis B treatment in general, with a little bit of a focus on hepatitis B reactivation and treatment, and then hepatitis C. Next slide. So there's going to be two reading suggestions for people in the audience. Number one will be the American Association for the Study of Liver Disease, the AASLD Hepatitis B 2018 guidance document. The other is kind of a living and breathing AASLD IDSA document, which is online and constantly updated. And that's really the go-to for hepatitis C. Next slide. So in terms of, we're going to start with hepatitis B. Globally, we know up to 400 million people are infected with hepatitis B, and it causes close to 1 million deaths annually. And most of the spread of hepatitis B is vertical, from mother to child. And again, keep in mind, this is not a big issue in the United States. It's a bigger issue in Southeast Asia, Eastern Europe, and Africa. Next slide. So this is an old slide, but still relatively representative of the geographic distribution of hepatitis B. And you see here in red the high prevalence areas, again, going to be concentrated mostly in Africa, Eastern Europe, and Southeast Asia. The yellow is the intermediate, and then the green is going to be the US and Western Europe, or lower prevalence. Next slide. Now, when we look at hepatitis B in the United States, it accounts for about 2 million cases, or about 5% of chronic liver disease and cirrhosis. Now, incidence, meaning new cases, has actually decreased, and that's because of vaccines, but the prevalence, the chronic cases, is actually increasing. And next slide. In the United States, most hepatitis B is, if you will, a sexually transmitted disease, spread through heterosexual spread, with some intravenous drug use there in red. Next slide. But the reason we're seeing a higher prevalence or more chronic cases is really people coming in and immigrating from other countries. And so remember, we said there was a huge amount in the red areas. And so when people came over, this was an older study, but looked at a good decade, and we see that a lot of people that came over from Asia, Europe, etc., were able to bring hepatitis B with them, unfortunately, and that's why we see more chronic cases in the US now. Next slide. Now, in terms of the phases of hepatitis B, and this is where I talk to my medical students and I get that blank look on their face, because hepatitis C guidelines are very easy and very straightforward. Other than a genotype, you don't need to remember much about hepatitis C. It's one virus. Well, hepatitis B is very different. It's almost like you have 4 different viruses. And if you look at the guidelines, you can really get lost trying to figure out what's an E antigen positive mean versus a negative. So this is a cartoon representation of the 4 phases of hepatitis B. There's 2 that are hepatitis B little e antigen positive, that kind of beige and blue, and then it transitions to e antigen negative, where they're e antibody positive. Now, what's happened is the way that the textbooks show it, you start with phase 1 and you progress to 2, 3, and 4. Well, that's just wrong, because what happens is you pick up whichever phase you pick up. So, for example, if you're in Southeast Asia or Africa and mom is in an e antigen negative phase, she's going to transmit e antigen negative to that newborn. So the idea that you have to go from 1 to 2 to 3 to 4 isn't really real, and that's why you'll notice in Southeast Asia we actually have more e antigen negative patients, and the children that pick it up start with e antigen negative. Why is this important? Go to the next slide, please. So we're going to look at these 4 phases, and it's important because we treat them or don't treat them differently based on these phases. So the first phase is the so-called immune tolerant phase. They're e antigen positive. This is that phase 1, very high DNA, but their ALT is normal. Next. And you'll see there classically we do not treat these people. You're going to notice that ALT tends to drive treatment decisions more than hepatitis B DNA. Again, very different than hepatitis C. Next. You then go into phase 2, which is e antigen positive, chronic wild type active hepatitis. This is what the textbooks always talk about. This is the high DNA, but the difference here is the ALT is high, and if you did a biopsy, there's inflammation there. Click it again. And these are people we treat. So again, the difference between 1 and 2 is the ALT being normal, we don't treat, or ALT being high, we do treat. So those are the 2 e antigen positive phases. Next slide. Let's go to the e antigen negative. And this used to be called the healthy carrier. We don't like that term anymore because what it implies is if you're healthy, you don't need to be followed up and nothing needs to be done. So the new term is the inactive carrier. Here, as we said, they're e antigen negative. They have a low hepatitis B DNA, and again, normal ALT. Keep saying it over and over, normal ALT. Next. No, we don't treat. So again, normal, don't treat. Next. And finally, we get to the e antigen negative chronic hepatitis. People used to call it, or still call it, a pre-core mutant or core promoter mutant. DNA is a bit higher, but again, same principle. ALT is high, inflammation is there. We're going to go ahead and treat these people. So again, there's 4 phases. 2 of them are e antigen positive, 2 are e antigen negative, but 1 and 3 and 2 and 4 are relatively similar. Next slide. In terms of natural history of hepatitis B, again, the majority of cases are picked up in the neonatal time, and what happens is the younger you are when you pick it up, the more likely you are to go to a chronic infection. As we said, in Africa and Asia, they pick it up as children. That's why they go on to chronicity. Whereas in the US, when it's picked up as a sexually transmitted disease as an adult, the far majority actually resolve the infection. So again, very different between Asia, Africa versus US. Now, of the people with chronic infection, you see 15 to 40% go on to a chronic progressive hepatitis, and they're the ones at risk for cirrhosis, cancer, etc. Next slide. Now, in terms of progression to cirrhosis, there are 2 factors. Number 1 is going to be time, and you see here that over time, you have a progression to cirrhosis. These were people with active hepatitis B. So the first thing is time. Next slide. The second thing is the hepatitis B DNA level. And so this was the old REVEAL Hep B study. And what it showed was for those people with active hepatitis B, the more virus you had, the higher the viral load, the more likely you would of going on to cirrhosis. Next slide. Now, you'll notice that liver cancer follows this similar pathway. So in those patients with compensated cirrhosis, the longer you wait, the higher the chance they develop cancer. Next slide. Same principle you saw before. Also, the higher the DNA in these people, the higher the risk of cancer. So again, time and DNA level drive the fibrosis/cirrhosis. They also drive the liver cancer. Next slide. So the goals of hepatitis B therapy are to ideally get the hepatitis B DNA undetectable, but at least suppress it to the lowest level, with a goal to prevent progression to cirrhosis, prevent liver failure, prevent HCC, which is hepatocellular carcinoma, and then obviously prevent death or the need for transplant. Lowering the hepatitis B and ideally eliminating it actually leads to histologic improvement, ALT normalization. If they're e antigen positive, you could hopefully lose e antigen, or ideally lose surface antigen, and maybe even, I'll put the word cure in quotations, maybe cure them. Also, there's a third kicker there on the bottom, which is if you can take mom with a high viral load, you can actually treat them in the late second and third trimester and decrease the risk of transmission. Next slide. So I'm going to show you 3 algorithms for treatment. And these algorithms are exactly the same with one kicker. The DNA level is 20,000 or it's 2,000. E antigen positive virus is a more healthy, robust virus. It gets higher DNA levels. So this first slide is going to be 20,000 as our cutoff. The next slide will be the E antigen negative, and you'll see that only has 2,000. It doesn't replicate as much. So let's stick with this first slide. This is just standard run-of-the-mill active hepatitis B. You're going to check a DNA level. If the DNA level is low, defined as less than 20,000, you're not going to treat them. You're just going to follow them every 6 to 12 months. Go to the other side. If the DNA is high, you're going to check the ALT level. Make it simple. On the right, ALT is elevated. You're going to go ahead and treat them. And we'll talk about the agents, but usually Entecavir or tenofovir, maybe pegylated interferon, though most of us don't use interferon anymore. Now, the gray zone in the middle is a high DNA with normal ALT, and I'm going to direct you to that box on the bottom left corner. These are the new definitions of normal when you're deciding about ALT levels and hepatitis B. It should be 19 or less for women, 30 or less for men, even if your lab has their own normal ranges. So let's go back to that area in the middle. So the Hep B DNA is high, but the ALT is normal. Generally there, we're going to follow them and see what they're doing. Remember that immunotolerant, that phase 1, we tend not to treat them with the normal ALT. Now, there is a caveat on the bottom there, which is you can consider biopsy if they're a bit older. The reason is that many of these people, especially from Southeast Asia or Africa, even though they may be young, they're 42, 45 years old, they may have had the disease for 40 or 45 years old. You might consider a biopsy to decide if you want to treat them. So keep this slide in mind. This is e antigen positive. Let's go to the next slide. Exact same slide, e antigen negative. The difference is the viral load that you use as a lower cutoff because this virus doesn't produce as much virions. So everything else the same. On the left, the DNA is very low, less than 2,000, just follow them. On the far right, DNA up, ALT up, you're going to go ahead and treat them. And then that gray zone in the middle, which is you can follow them and or consider a biopsy depending on what your thought process is. Next slide. Now, the third algorithm is what to do with a patient with cirrhosis. Now, there's compensated and decompensated. Decompensated meaning formation of liver issues such as ascites, varices, hepatic encephalopathy, etc. I don't think anyone would argue on the right side of this slide that if they have any active hepatitis B DNA floating around, you should treat them. A, you might prevent them from needing a transplant, or B, if they're going to need a transplant, I want them to go into transplant with a negative or at least the lowest hepatitis B level. Now, I'm going to take that right side a little further. My version, I don't care if they have active Hep B or not. If they're decompensated, and I think it was from Hep B, even if their Hep B is negative, I usually just leave them on therapy. That one you could debate, but at least if there's any hepatitis floating around, treat it. On the left side are the compensated patients, and most of us in the US would treat whether the viral load is low or high as long as it's detectable. They did give you the option of observing them. When I spoke in Southeast Asia many years ago, I told them my preference to treat, and they had a very fair point, which was from a financial standpoint, they can't afford to treat 100 or 150 million people, and I understand that. In this country, I would say, though, if you have cirrhosis and a positive viral load, you probably should treat them. And again, I would avoid interferon in that group. Next slide. Now, in terms of choosing your drugs for Hep B, you're playing a balancing game of efficacy versus resistance. Next slide. So these are the FDA-approved treatments for chronic Hep B. You see my little text box there that usually acute Hep B doesn't need to be treated. It usually resolves on its own, though if you have liver failure, you might consider treating it. So let's go back to the left for chronic Hep B. And I'll tell you that we don't use a lot of these. So click it one more time. So what we're going to do is we're going to leave the three things that are still in existence realistically, which is pegylated interferon, which, as I said, I haven't touched an interferon in 10 years. Very few people use it, but there still could be a role for it. It's a shorter course of therapy, 1 year, compared to the orals, which tend to be long-term or even lifelong. But realistically, in the bottom is what you're going to use, Entecavir or tenofovir. And there's going to be two formulas of tenofovir. And I'm going to spend a couple minutes talking about TAF, because TAF is the newer formula, and this is, Vemlidy is the trade name for this. And the reason I'm going to talk about it is because not a lot of people are familiar with it. When I go out and talk about hepatitis, many of them don't seem to have an idea of what that drug is or what the difference is. Next slide. So as we said, Entecavir, which is now generic, or the two tenofovirs. And TAF is, as I said, the newer agent. And you'll notice from the AASLD guidance paper, it has a better safety profile than TDF or the old Viriad, but similar antiviral efficacy. And so let's take a look at that. Next slide. So tenofovir in general is a nucleotide analog, and TAF is a tenofovir prodrug. And if you remember from standard TDF, tenofovir, you use 300 milligrams. TAF is concentrated in the liver cells. You can get away with 25 milligrams. That may explain why there's lower side effect, because there's lower systemic exposure, leading to less renal and bone toxicity. Next slide. And so if you look here, the first question is, are they as good? Is the TAF as good? Along the top, what we see on the left is an e-antigen negative, the right an e-antigen positive, and you see that in terms of suppressing hepatitis B DNA, the gray line, which is TDF, and the red line, which is TAF, superimposed. So efficacy, they're the same. And actually, if you go to the bottom, looking at ALT normalization, the TAF is actually a bit better. And so, again, it might be better in terms of suppressing the ALT. Next slide. But in terms of safety, this is where probably we're more concerned, or more interested, I should say. And you'll notice here in the red line, we have a 1.2% or 1.2 drop in GFR over 2 years and actually 1 year as well with TAF, whereas we have about a 5 drop with TDF. So we see an improvement in renal toxicity with TAF. Next slide. And I can even take it one step further in a switchover study where at 96 weeks, where you switch those people that had been on TDF and put them on TAF, you actually see improvement in their renal function, and they actually reach the level of those who had just been on TAF. So it's safer, it can actually even rescue them. Next slide. We'll see the exact same thing here on bone mineral density. You have more drop in terms of percent change in your bone mineral density at 2 years on TDF compared to TAF. Next slide. And finally, the same principle with renal. You actually see an improvement here in bone density when you switch them over to TAF. Next slide. Now, in terms of treatment, what do we see happening? Well, this was a study many years ago, but looking at hepatic decompensation in those with chronic Hep B, and you see here, this was an old drug, lamivudine, was dramatically better than placebo. This is the amount of progressing, so we had a lot less people progressing. And in fact, this study was stopped early by the safety monitors. Next slide. And we see the same principle here of liver cancer. And again, lamivudine had a much lower risk. And similar studies have shown that with the newer agents, Entecavir, tenofovir, we either have the same data or we expect the same data, and we've seen it in small studies. So this is kind of the support of treating them for their hepatitis B. Next slide. Now, this is really exciting data. There's a good rule of thumb, which is cirrhosis does not disappear. Once you have rock-hard fibrosis, you can't get rid of that. Well, that is not true in hepatitis B. I just picked a study using Entecavir. I could have shown other studies. But here, we're using Ishak, so level 5 or level 6, which is that beige and the red on top. These were people with cirrhosis. And notice what happened at the 5-year study. No patients had cirrhosis. So you actually can get regression of fibrosis and even cirrhosis with long-term Hep B therapy. Next slide. So when I show you some of my pictures, I'm an avid photographer. It means I'm changing gears. So this is, I think, Emerald Bay up in Lake Tahoe. So next slide. Now let's talk briefly about hepatitis B reactivation. I want to talk to a general audience, a general GI audience, and they oftentimes tell me, I don't see a lot of hepatitis B. It doesn't enter my practice. Well, it kind of does, in that you may not be seeing active Hep B, but you may be seeing people who have the potential to reactivate Hep B, people that might go on chemotherapy, people that might be seen by the dermatologist, rheumatologist, gastroenterologist, going on biologics, anti-CD20s, TNF inhibitors, or people getting transplanted, or interestingly, because of hepatitis C therapy. Next slide. Now, hepatitis B reactivation is in essence quiescent hepatitis B turning itself on. As you see there from the arrows, it can be severe, and if not recognized and not treated, can go into acute liver failure and death. Obviously, that's the ultimate bad outcome, but the bottom arrow is also a bad outcome because if you have a significant hepatitis, you may have to delay or even withhold chemotherapy or immunosuppression. Next slide. So in terms of screening, you should screen these patients with Hep B surface antigen and Hep B core total antibody, not an IgM, a total. And again, especially if you have an Asian population, an African population, Eastern European. And you're going to kind of break them down into a couple groups. There's the surface antigen positive. They're going to be easy, as I'll show you. Then there's the isolated core. That's surface antigen negative, core antibody positive. Notice that in all of this, just having a hepatitis B surface antibody is not protective if you've had hepatitis B before. Let me say that again. If your core is positive, your core, that means you've had Hep B at some point in your life. Just having that and a surface antibody does not necessarily protect you against reactivation. Next slide. And again, this is the group we're going to focus on next. Now, in terms of Hep B reactivation rates, as I said, many people tell me, well, I've never seen reactivation. It doesn't happen. Well, look here in the surface antigen positive patients getting chemotherapy, up to 50% of them can reactivate. And even in the just core, up to 20% can reactivate. You'll see on the bottom, not nearly as high in the rheumatologic patients, but given the fact that everybody and their brother is on these drugs now, those numbers are still probably significant. Next slide. So when you decide if you're going to treat or just watch them, you have to assess the patient's risk regarding the Hep B. You're going to check the surface antigen, is it positive or negative? You then have to look at the medicine you're going to use, and I'll show you that the B cell depleters or the CD20 antagonists like Rituxan are more dangerous, and also certain types of transplant like bone marrow is considered high risk. Next slide. So the way that I look at it is this. If they're surface antigen positive, they're high risk for reactivation, defined as over 10% risk. You're going to treat them, and I'll show you that in a minute. If their surface antigen is negative, their DNA is negative, and they only have a core, you're going to divide them up into high, moderate, and low risk, and then you're going to make your decisions of what to do. Next slide. So this is how I do it. I treat the high risk, and then I'm going to, in the isolated core, I'm going to either treat or monitor, and I'll show you what I mean here. Next slide. So this is for the surface antigen positive patient. You'll notice that pretty much you're going to treat them with any of those agents on the right side of the blue. You're going to treat them on any of the moderate agents, and this is important. This includes your TNFs, your cytokine-based, your immunotherapy. So pretty much, unless they're getting very low risk on the bottom, they're short steroids, azathioprine, etc., you're going to be treating them with Entecavir or tenofovir. So this is the surface antigen positive. Next slide. For the surface antigen negative who just has a core, there are two guidelines out there, and that's the 2015 AGA and the 2018 AASLD, and there's been a big change here. So let's start in the top box. If they are core isolated alone and they're getting a high-risk immunosuppression, that's the Rituxan or similar anti-CD20 or a bone marrow, you're going to treat them, period. Again, Entecavir, tenofovir most likely. But if they're in the moderate drugs, again, surface antigen negative, if they're in the moderate drugs, this includes your TNFs, your standard chemos, a lot of your IBD drugs that are cytokine-based. Here, we're going to follow them with Hep B DNA every 3 months and LFTs, and we're not going to treat them unless they actually reactivate. And again, that's a difference between 2015, where we treated prophylactically, and 2018, where we monitor. Next slide. So the idea of reactivation prevention is when you know you're going to treat, you want to treat either before chemo or ideally about the same time that you start the chemo. You want a high potency, low resistance drug like tenofovir or entecavir. You're going to treat for the duration of the immunosuppression plus another 6 to 12 months, generally 12 months if it's an anti-CD20, 6 months for the others. Next slide. Now, hepatitis C drugs, these DAA or direct-acting antivirals, you can reactivate hepatitis B on these agents. There's sort of a dominant and submissive type of a role with hepatitis. Usually, hepatitis C is dominant and the hepatitis B is inactive. But in theory, when you give them Hep C therapy and get rid of the active Hep C, hepatitis B can reactivate. And you see there on the bottom a few studies that showed that this reactivation rate might be high, and with hepatitis B surface antigen positive, could be as high as 24%, but in the isolated Hep B cores, it was pretty low, 1.5%. Next slide. So you don't need to read all this, but this was the AASLD guidelines for how to manage Hep B reactivation. Let's go to my guidelines on the bottom, which is I screen for surface antigen, core antibody, and surface antibody. If they're surface antigen positive, I prophylactically treat them, again, entecavir, tenofovir, and I keep them on that for about 12 weeks after stopping the DAA for Hep C. On the other hand, if they're core only, those people I just monitor about every 3 months during their Hep C therapy. I only treat them if they reactivate. In treating over 1,000 patients, I've had one patient reactivate that was in that core group. Next slide. So let's change gears and go to hepatitis C. I know it's kind of a big talk to give Hep B and Hep C, but that's what I was asked to do, so let's do it. Next slide. So again, a lot of prevalence numbers here. You'll see numbers ranging from 0.1% up to 5%. Estimated about 175 million people in the world have Hep C. Now, in the United States, you'll see various numbers from 2.5 million to 7 million, and I'll show you some important points. But suffice it to say, only about half, and some would say 25%, have been diagnosed. Of those, 17% had their disease staged, 16% have been prescribed DAAs, and only 9% have achieved SVR. SVR is cure, and that's kind of troubling given the fact that the drugs are 97 to 99% effective. What it means is we're not diagnosing enough and we're not treating enough. Next slide. This just shows we'll go to the far right. The brighter teal is the people that are actually diagnosed, and the lighter or darker teal up above is the people that are unaware. And it could be 75% of people with Hep C are not aware of their infection. Next slide. Now, we got pounded into our head the idea of the baby boomer cohort. We had to screen the baby boomers. And what that came from was the idea that it was difficult to sit and ask your patients, are you a drug user? You know, what did you do? Did you share dirty needles? Well, if you had somebody who's now a lawyer, a doctor, a nurse, an APN, whatever, they don't necessarily want something on their chart that they did 30 years ago. So we sort of switched from risk-based screening to age-based screening. So anybody born between 1945 and 1965 got screened. And this was why, because 70 to 80% of Hep C patients were in that group. Next slide. But the times are changing. So we're seeing a very different change in the epidemiology of Hep C. We're seeing new acute Hep C, and this is from our young IV drug abusers. And in fact, you see there, the CDC commented that there were over 3,000 cases of acute Hep C reported in 2017, but they estimated on models that it may have been closer to 44,000. So again, some not recognized, some not reported, but a very big shift in the epidemiology. Next slide. And you'll see here, this was an interesting slide. The black bars represent the opioid overdose epidemic we're seeing, and you see it rising over time, and you'll notice the white dots in right bar is the number of acute cases of Hep C rising. So really no surprise to anybody in this audience, but we're seeing more and more acute hepatitis C with more and more opiate use in the younger population. Next slide. And this is what we now have. We have on the right side of our bar graph the peak, and that was the age-based or that baby boomer cohort, but we're seeing a much larger spike in this acute cohort from the younger IV drug users. And so this has shifted us from risk-based to now age-based to now universal screening is what's recommended. Next slide. And you'll see here CDC, AASLD, and the USPSTF are all now recommending the idea of screening pretty much everybody from age 18 on up. And you can screen below 18 if they have risk factors. But the point is, this is now getting covered by pretty much every insurance. So now anybody who walks in my office gets a Hep C test, even if I'm seeing them for fatty liver or liver cyst, etc. Next slide. Now, in terms of the impact of hepatitis C, Hep C is still a leading cause of liver transplant. It's getting pushed down a little bit by fatty liver disease, but it is still a leading cause. And for those who are surprised by the bottom right figure, it has now exceeded the number of deaths compared to HIV. That happened over a decade ago. And that still surprises some people. They look at Hep C as a mild disease and HIV as a severe disease, but the number of deaths from Hep C is much higher. Next slide. Now, in terms of mortality, everything is hepatitis, everything is liver. Well, is it? Let's talk about that. This is the REVEAL Hep C study, and what you find there in the lavender bar is that the cumulative mortality is much higher in the people who are Hep C antibody and Hep C RNA positive compared to people who either have no RNA or no Hep C at all. Next slide. And the assumption is it must be from liver there on the left. And obviously there is a dramatically increased risk of death from liver diseases. But look very importantly to the right. Extrahepatic diseases are almost double in people with active Hep C compared to those who aren't. Next slide. So let's talk about the natural history of Hep C. This is different than Hep B in that the far majority go on to chronicity even as adults. So 70 to 85% of acute Hep Cs will go on to chronic. And again, that does mean a decent percent, 15 to 30% will cure themselves. Now, of the people with chronic Hep C, over time, they can develop cirrhosis, about 20 or 25%, usually over several decades. Next slide. So we have time. We have decades to treat them. But once you reach cirrhosis, what I'm showing you now are annual rates. Roughly 5% of people with Hep C cirrhosis will annually decompensate, get liver cancer, and or die. So if you're going to treat them, you want to get them between the chronic hepatitis and the cirrhosis phase. Next slide. So just as a reminder, keep in mind there are genotypes of hepatitis C. There are genotypes of hepatitis B. We don't really pay attention to them. But with hepatitis C, suffice it to say, we have 1, 2, and 3 in this country, a little bit of 4, and very, very little 5 and 6. But again, it kind of depends what population you're taking care of. Why am I showing you this? Because some of the drugs treat every genotype, some of them don't. Next slide. So the goals of Hep C therapy are the SVR. That is the key, the sustained virologic response, defined as the hepatitis C RNA being undetectable 12 weeks after stopping therapy, the so-called SVR12. We consider this a virologic cure, and you can tell the patients they are cured if they attain this. That does not mean that their cirrhosis goes away. It just means the active inflammation of the Hep C part goes away. Next slide. So the benefits of Hep C cure is there is a decrease in overall mortality, whether they have advanced liver disease, that's 79% reduction, or even early liver disease with a 60% reduction. There is a significant decrease in the risk of liver cancer, decrease in liver inflammation, fibrosis progression hopefully stops and goes backwards. Symptomatically, they get better. Now, I'm going to point out in that one bullet there, the second main bullet, decrease in liver cancer. There was initially some concern from a few articles that these agents may actually predispose people to liver cancer. I think most of us feel that those were just simple small case reports. That is not the case. So the benefit of Hep C therapy and cure dramatically outweighs any risk of developing liver cancer from it. Next slide. And I'll show you a really nice abstract from a few years ago. And this was the effect of SVR, and not a small study, 34,500 patients. And red meant they got an SVR. The teal means they did not have an SVR. And what you see there in the upper left corner, 5-year risk of all-cause death, whether they were run-of-the-mill Hep C, cirrhosis, or Hep C HIV, dramatically lower in all categories with the SVR patients. The next bar graph over to the right, the 5-year risk of liver cancer, again, dramatically lower in those patients who achieved an SVR. And then the bottom left, you actually see that almost none of them had to go on to liver transplant. So I think all of us are very comfortable knowing and talking about the dramatic improvement in patient outcomes with an SVR. Next slide. So this is kind of where we were at and where we are. And so when I started this game, we were using interferon, and we got 10%, maybe 20% cure rates with horrible side effects up to a year of therapy. We then added ribavirin. We then pegylated the interferon. We then add on the first generation protease inhibitors, and then we finally get to the DAAs, or direct acting antivirals. And, you know, this is where we're at. So let's talk about this data a little bit. Next slide. So in terms of nomenclature, the minute I start talking these names, everyone kind of blanks out and kind of loses it. But they're actually much simpler than they seem. There are 3 types of roots to these names: Previr, Asvir, Buvir. If you see Previr at the end, it's a protease inhibitor. And if you see Asvir at the end, it's an NS5A. If you see Buvir, such as Sofosbuvir, that's an NS5B. So again, all of the companies are using the same ending to all of their drugs. So you don't need to memorize every drug name. If you just eyeball the generic, you will know what composition you're seeing, because they usually have combinations. Next slide. Next slide, Scott. Thanks. So in essence, there are 3+1 drugs out there. You still might be able to get your hands on some of the older DAAs, but in essence, this is what we're seeing. On the bottom is Sofosbuvir, NS5B, Velpatasvir, an NS5A, Voxeloprevir, a protease. Again, that's how you would use to know what you're dealing with. That's for people that have failed the other therapies. You're likely never going to use that drug, or very rarely use that drug. So let's just concentrate on the top. Sofosbuvir, Ladipasvir, which is Harvoni, sofosbuvir, velpatasvir, which is Epclusa, glucaprevir, and pibrentasvir, which is Mavorite. So again, you see the top two are an NS5A and an NS5B, and Mavorite is a protease inhibitor and an NS5A. Next slide. Next slide. So for Harvoni, it's only approved for genomes 1, 4, 5, and 6. For Epclusa, pan-genotypic. For Mavorite, pan-genotypic with a protease inhibitor. The only reason that's important is for a decompensated cirrhotic, you want to avoid a protease inhibitor. That's a very, very small subset of your patients. Next slide. So how do we choose these things? And this is always the questions that come up. Well, if they have genotype 2, 3, they're not a candidate for Harvoni. But again, for the 1 and 4, they are. So again, you want to do a pan-genotypic, you can use Epclusa or Mavorite. Cost and insurance sometimes have a preference. There are sometimes drug-drug interactions. I personally use a specialty pharmacist, and I highly encourage you to do that, though there are some websites, there are some phone apps that can actually tell you if you have a drug-drug interaction with your patient. And then finally, don't use a protease, something ending in the word Previr, with decompensated cirrhosis. You can use it with compensated. Next slide. So I like to be very scientific, and what I'll tell you is, in all honesty, in my mind, and I literally tell my patients, in my mind, most of the time, this is Coke versus Pepsi. And I think that the efficacy is essentially identical, and they're all very well tolerated. And I can safely say I believe I've treated the oldest person possibly in the world at age 99 and a half, because she really wanted to be treated. She was cured, and she had absolutely no side effects. So I can say that even ages, we can treat anybody. Next. So in terms of, I'm just going to pick a little bit of efficacy data here. We'll start with sofosbuvir, velpatasvir, or Epclusa. These were treatment-naive, treatment-experienced, non-cirrhotic or compensated cirrhotic. You see that the SVR rates, 97 to 99%, discontinuation rates due to side effects, 0.2%. If we go to the Mavorite, same thing, again, treatment naive in this study, but non-cirrhotic, compensated cirrhotics, SVR rates 98%, discontinuation rate 0.1%. More important than these registration trials, the real-life data were identical in both of these drugs. So the point is, it's not just what the drug company comes up with, this is what real-life treatment is like. Next. Now, I will bring up a concept that some people aren't aware of, which is this new idea of the simple basic Hep C. So we all do a workup. We generally do a elastography or fibroscan. Some people do a biopsy. We do labs. We follow them with labs on therapy. We see them back in the clinic, et cetera, et cetera. Well, there's money. There's potential issues with some of the testing you're doing, especially a biopsy. And there's obviously cost and compliance here. So one of the questions was, what about the run-of-the-mill simple Hep C? So if you have a person who has nothing on the right side, they don't have Hep B, they don't have HIV, they've never been treated, they don't have end-stage renal disease, thrombocytopenia, cirrhosis, etc., you might be able to get away with a very simple, straightforward treatment approach. So, initial assessment, day one exam, make sure there's no cirrhosis. Number two, very simple labs. Notice, Hep C RNA, not even a genotype. I'll tell you why in a second. You're going to calculate a non-invasive score like a FIB-4 right off your phone app, right off your computer app. And I think my video stalled here. Let me try and uninstall that. Oh, well, sorry, I'm sort of sitting there with an interesting look on my face. And if they don't have cirrhosis, then you can jump into treatment. Next slide. So here's the approach. So on the upper left side, you look for any potential drug-drug interactions. You pick either Epclusa or Mavorite. You pick a pan-genotypic regimen so that you don't need to worry about the genotype. You do treatment. You then see them with labs 12 weeks after treatment is stopped. If they're negative, they're cured and you're done with them. If they're not negative, if they're positive or the ALT is high, then you probably want to send them to a specialist. One more click. So theoretically, this simplified approach is no labs, no testing from the first day you see them until 12 weeks post-treatment. So you can see how this could be amazingly cost-effective and cost-saving for the patient and for the system. Next slide. And again, this whole idea, when I go out and talk to people, they talk about, well, cirrhosis, I can't treat them. Children, there's no treatment. They had a transplant. We know classically black males have low rates. We shouldn't treat them. PWIDs, or people who inject drugs, shouldn't be treated because they're going to get reinfected. Well, a lot of those are myths. And in fact, you see there the PWIDs, the reinfection rates tend to be quite low and oftentimes less than 10%. Next slide. And in fact, for the PWIDs, the people who inject drugs, the latest AASLD guidelines will tell you active or recent drug use or a concern for reinfection is not a contraindication to Hep C therapy. In the state of Ohio, they're not even looking at or necessarily relying on drug screens anymore to approve a patient. Next slide. And I just picked some studies here. These were real-world studies, but take a look here. This was using Mavorite. To the right there, they're overall, these were difficult people. These were active alcohol users, active drug users, psychiatric disease. The SVR rates were still 98%. So the point is, this idea of, oh, they're too hard to treat, I can't treat these people, it just isn't true. Next slide. So I'm going to end it there. And again, I apologize that my video seems to be locked, but I'm going to go ahead and open it to questions. Next slide. And Scott, I'm not sure how you want to do the questions.
Yeah, you might be able to click your camera on and see if it reboots for you.
Okay.
And then click it on again. That might work.
That looks better.
There you go. Now, I've been monitoring the question box, and thank you so much. And let me just click off the sharing screen. That should take away the other. Stop sharing. Well, that shows something else. So if there are questions that folks have, then put them in the chat box, and then we can ask them here. And I'm not seeing anything yet. We're about 4 minutes to be at time, so you're right on time. That's the professor in you, I think. And I forgot to mention that you're a professor of medicine at Case Western Reserve University School of Medicine. So that really came out of your presentation style today. So thank you very much, Doctor.
Oh, absolutely. And I figure this is going to be an ongoing sustained presentation, so we'll probably get a lot more questions down the road. And
I do have one question. Does the presence of EVs with or without banding make the patient decompensated? What about HCC?
Yeah, it's an interesting question. How do you define decompensated? And this gets brought up all the time. For example, if someone has varices that you've obliterated and they don't have them anymore, are they decompensated? Per the guidelines and the drug company labels, if you have varices or had varices, you are decompensated. Same thing with liver cancer. If you had liver cancer in the background of cirrhosis, even if it's treated, you are still considered to have decompensation and liver cancer.
Okay. And while I wait to see if there's another question, I just want to let folks know that the Northeast Ohio Liver Alliance is a new nonprofit. It started by physicians, actually, to promote liver health and support people living with liver disease in Northeast Ohio. All funds raised stay in Ohio to support community-based education, such as this, advocacy, and research programs. So with that, Doctor, it does not look like we have any questions, and we're basically at time. So thank you very much for being part of today. And thank you for everyone who attended, but this will be recorded and uploaded on our YouTube channel. And with all of our educational programs, please know that this is for educational purposes only. This is not to be considered as individual advice if you're a patient or caregiver, but rather to prompt some questions that you might ask your primary care doctor the next time you're in. So thank you very much for being here and have a great day.
Thank you. Thank you very much.